CCG. I've been doing this webinar to let our colleagues know what we are doing for the last 18 months. We're doing as a diabetic care plan and annual review as a part of Year of Care. Um, the main purpose for this care planning was to make sure that to integrate all the templates in one place, and mainly the SystmOne template, and the care planning approach mainly from the Year of Care 2008. And as to maintain all this in one place, it will be useful for all the practitioners, including the ICDS, which is the secondary care team. So at the end of the month, they're going to be on SystmOne Live as well. So they can see what we are doing and we can see what they are doing for our patients when we are sending them to the secondary care. So it's like a practical interactive demonstration, which I'm going to do with a live test patient um, on SystmOne, and also discuss about the achievements, what we have done. And then after end of each clipping, I would ask for questions and a feedback at the end, if you can, please. And if you have any queries, please email either Fahad, Mateen, or myself, S. Panala. The emails are there. So we'll send the slides later. Thank you. The reason for developing the SystmOne template, as I said, which is to integrate all services in one place, standardize the care all over the Bedfordshire, because we all been using SystmOne, so it will be useful for us. And also empowering patient in managing their own medical condition, the long-term condition. As we said, and standardizing that, and also achieving all the treatment target, the 8 KPIs, and to standardize that care processes, and also referrals to the structured education. Earlier, we used to have reduced referral rates to structured education. Either the patients were referred or not attended. So we wanted to standardize the whole system as this. And we have taken the data, it includes the QOF data, the read codes, and also the NDA, National Diabetic Audit read codes. So we are reducing minimizing the discrepancy of the read codes as well. And we will be tracking the progress year on year, including the impact on reducing the unplanned admissions and also amputations, including both minor and major amputations. So how do we deliver the personalized care plan? As I said earlier, it's a Year of Care Diabetes, which was 2008, nearly 11 years ago. This was the main, and it was an exemplar diabetes care at that particular time. So they said the Year of Care is as a planning house, where you can see the commissioning coming on the foundation, and then the collaboration of the primary care along with the healthcare professionals, and engaging the patient and empowering the patient. So it's all a collective win-win situation, which we can achieve. So personal care planning is encouraging the patient so they can manage their own diabetes, empowering them with the knowledge of diabetes, with support from the organized proactive team. And this was taken a slide from the Year of Care. So the good partnership between the patient and the doctor needs to be, and the patient and the healthcare professional needs to be taken for the better outcomes of the condition. So they're transforming this annual review into a constructive and meaningful dialogue between the healthcare professional and the patient with diabetes. So here, what we are looking into a patient's journey. Ideally, we need to have a standardized care where the patient or the person with long-term condition diabetes, we are mainly concentrating on type 2 as per the primary care is concerned. The patient will be invited for an annual review, and the blood test is at the step 1, where they come and see the nurse or a healthcare assistant for the appointment to carry out the following things, which are like to check for the basic blood glucose control, kidney function test. The blood card will be issued as per the ICE diabetic panel, where there says diabetes plus ACR annual bloods, the second one on the ICE. So we tick that box, and then automatically that will be generated. Patient needs to be all the data input, with including weight, waist measurement, blood pressure, heart rate, and feet examination. Once this is done, the patient will be given a blood card, and a scheduled task will be sent by the admin team. Follow up in 2 weeks' time to send an appointment for the step two. In the step two, we'll be sending the results along with appointment for the patient, and a column for the patient to comment on those results or anything else which they have any queries about their health condition. Is again picked up from the year of care. The step three, when the patient comes with the empower with their own results, then they'll be writing up their queries or comments on that, and then come and see the diabetic nurse or practice nurse or the GP who lead with diabetes. And then the remaining part of the discussion will be opening up regarding their lifestyle management, how they're going to cope with this diabetes, which includes mental health and also other medication, other comorbidities could be discussed. So to do this, I think we are at the moment we are doing for the last November onwards, 2017. Initially, there was some problem with timing, so but now we got a good plan in our practice where we get 15 minutes from the HCA, 15 minutes for the practice nurse or GP, two different appointments. So ideally, when some surgeries don't do the blood test on at the same time, so we have another alternative path, which is the step one. Everything will be done as mentioned earlier, but the patient will be given a blood card. The patient goes back for the blood test, and then, as I said, the scheduled task will be sent to the patient along with the results. Then the patient comes back to the clinician in the second step, which is the step three on this one. So I'm going for the live demonstration of the SystmOne on a test patient. I is a fictitious patient here. Just a technical here issue. If you have any queries, please mention now before I go into the live demonstration, please. Thank you. I'll just give a few seconds. You can raise the hand. There's a hand button next to your presentation if you need. Then we can discuss, or else I can go for the next step. Thanks. Right. I'm just sharing the screen. Hope you are all seeing this one, which is a test patient, Mini Mouse. Here, to get into the template, we normally type on the left side as long-term care LTC. So it should pick up diabetes version 4 care planning. There are different ways, different practices have different ways of doing it. In my practice, we normally go into the long-term conditions, put all in one place. So here we can pick from there as well. So either way, this is easy method. On the left lower box, LTC, and it picks all the long-term conditions. So diabetes at the moment is on the top, so I just picked that. This is how the one looks like. So we got into the review stage one, put lifestyle. Hope you're seeing this particular one. And here we are putting as all KPIs in one place. And when the diagnosis was made for diabetes, and when was the referral made. So we are tweaking some things here. So in the next updated version, this will be gone, where it will be only a referral letter to the Desmond done, because now they're merging Desmond and Adam together. All the KPIs as HbA1c, the previous one, the current one, cholesterol, when the date, and all those things, and UCR, ACR, and also blood pressure, weight, all KPIs in one place. As I said earlier, ensure the patient given the blood and ACR card. So this is the scheduled task to be mentioned here. So when you send a scheduled task, we can add it that way. So depending on your practice, how their policy is. So when the patient comes to see the HCA, and also there's one more, the record sharing. As I said earlier, the ICDS team will be looking into this. If you're looking for the record sharing, you need to take the consent from the patient and make sure that record is shared and the data is consent given depending on what the patient says. When we refer to the ICDS, that's the one. But that will be coming next end of the month. Diabetes consultation, seen in the diabetic clinic, review at home, medication review, joined with the community diabetic specialist nurse, which is ICDS. Sometimes they can come into surgeries and help us for virtual clinics, and also some patients who are difficult to manage. So very helpful. So we made into different colors so that we can not forget. This is the first consultation in the greens, the second consultation all in the blues. So easy to remember. So initial, as I said, the data input in the first consultation, height, weight, BMI, and wherever is important, we put it in the red bit so that we can read those and act upon. Especially in this scenario, it's BMI is more than 28, consider refer to weight management. So it comes into BMAE patients as well, where black and minority ethnic community, which is 27.5, but that is standardized. Similarly, with blood pressure lower than 135/75, if the patient is CKD, and all the data needs to be inputted, including weight, waist, circumference as well. Smoking status, physical exercise, the drop-down boxes, no exercise, light, moderate, or heavy. Just tick accordingly. Smoking status again. Here, we didn't put as a smoking advice given at this time because this is a data input. But when we come back to the blue ones, which is here, so we have put that incorporated there. So we had this query in the past, so I just mentioned earlier. Similarly, alcohol intake. So it is mainly this greens are for the data input. Of course, we can give advice. Retinal screening, they are attended or not attended. If they have not attended, usually the HCAs or the clinician who is seeing the patient will put in the note, so to say in the free text here, that not attended, so we will refer to the patient, or they can send a task to the clinician looking after. Coming to the next one, stage 1, foot examinations has taken the whole page, as you can see. So diabetic foot examination, and the foot care pathway. If you have issues with care pathway, there's one on the top right. So if you click that button, it opens up into the GPRef, and then that's how we can see that. So it's on there. Sorry, it's on here. It's opening up now. So this is the pathway from the podiatric team. And all the foot pulses, both posterior tibial and dorsalis pedis on both legs, to be examined, including the 10-gram monofilament foot sensations. And the deformities or ulceration need to be addressed and documented. Here, once the second one comes, as we discussed earlier, the interim results will be sent to the patients after the first step. The interim results looks this way. You just click the button on the left. It's again taken from the year of care, which includes all the patients' test results and the comments, including the appointment time. So we have surgery, the test results here, where we can populate the appointment time and location as well. So this is where we important. What aspects of your diabetes would you like you to discuss? Most patients come back with this patient paperwork and then write up their what we want to discuss. What aspects of diabetes would you like to more information about? Especially what medications to be taken. Can we cut down the medication, doctor? What are the steps next? Medical checkups. Is there anything else they want to discuss? Are there any particular relevant for the patients? Giving of smoking, alcohol, all those things, which also we put as a mental health in the lower layer, low mood. Foot care, everything has been added. And then comes the HbA1c, date, and then if they want to make any comments, blood pressure, cholesterol, so all the kidney tests. And we are discussing with the lab at the moment about the non-HDL because at the moment we are not getting that correct read codes populated. So we are in a process of discussing with the biochem lab in Bedford Hospital. So at the end, the patient can write their own comments and they come back and then we can discuss further. Includes exercise, diet, smoking, feet examination, where is all the KPIs. Coming to the next step, then the patient would have got the results and they made an appointment, come to see the practice nurse or the GP. So from here, all this time we were doing the data input, now we are doing the data output and discussing with the patient where the patient already got their results in. So they're not in a dilemma of what the results could be. So they already know what it is. So that will be easy to take forward from the consultation. So dietary review, so we can document whatever we document here, we'll normally pick it up in the leaflet, the care plan which we give the patients. And again, in the red bits, as I said earlier, if the BMI is between 28 to 30, consider weight management. But if the patient's mainly taking the insulin or sulfonylureas where the risk of hypo, so this needs to be provided with the hypoglycemic leaflet as well, because with the weight management, if they're losing weight, they may not require that amount of medication, especially insulin or sulfonylurea tablets. Hence, that was mentioned in the caution there. And again, structured education leaflets can be given from here, and hypoglycemic leaflets from this one. Yes, it opens up straight into hypoglycemic leaflet. It's part of the trend leaflets which we got into PDF. Again, I can document about this, and especially when we are referring the patients, this we currently put as mandatory both for diabetic education. So we're taking all these. It's a bit confusing now. So we put as referral made, declined, or completed. We're taking the other ones like not available because it is available. It was not available initially, so it is available now. And this one we are taking it out as well. So it will be less crowded. So that will be coming up end of this week, today or tomorrow after this webinar. Unfortunately, it was supposed to be this morning, but it was not done for some technical reasons. Same with weight management. We are just referral made, declined, or weight management completed or unsuitable for weight, for especially patients who are not suitable mainly for cardiology reasons like heart failure or wheelchair bound, rheumatoid arthritis. That's what other associated comorbidities. So we can document the physical activity and the brief intervention of the physical activity. If the patients are not keen, then we can say you can decline that. Similarly, smoking, alcohol. Mainly these two, the structured education and the weight management, have been put as a mandatory at the moment. So all the referrals can be made into the last column on the right hand side, which I'm going to do it as we go through. Going to the next one, lifestyle 2, and discussing with the patients ways to inform DVLA, especially sulfonylureas, patients on insulin, which may cause lower their BMs. And also there's a leaflet about trend leaflets, which you can open. We just noted there's only one page attached to it, so we are getting the second page attached as well. Apologies if we haven't done before. So this is coming up from tomorrow. You'll be seeing the new 2 pages. Same hypoglycemia and how many episodes of hypoglycemia they had in the last month. So if you put that and then what they think about hypoglycemia is, and then we discussed about hypoglycemia, and you can write the free text there if you need to be. And same thing, we can give the leaflet accordingly. And the next one is the mental health issues, especially depression. The NICE recommends that any patient who suffers from long-term condition, we need to be ruled out with mental health. So questionnaire, mainly the top two of the PHQ-9 questions. If they got S to these two questions, if they say no, then put normal mood symptoms. That's all right. But if they don't, then we have to go for the next step, which is screening the PHQ-9 as we normally do. But some patients don't want to do that, then we can decline and then take it forward. And looking at the PHQ-9, these two needs to be filled in along with these two. If you don't, because they're all interdependent when we do the care planning completion. So these are mandatory. So when we think that patient needs to be referred to the mental health team, and then the CCG has got a contract with ELFT for the IAPT team, patients with long-term conditions, that they can be seen at a different path. So I put it in the red here. We have said that consider referral to mental health well-being service. Again, all in the referral tab in one place. Next step. Patients who are on insulin to be checked for the insulin site. Male patients for erectile dysfunction. And all the reports are co-filling linked, so as you can see on the patients with age group of 16 to 45. We need to discuss about the pre-pregnancy plan for the diabetic patients. And this is a separate part, but of course, if the patients are not planning for that, then it's S. We will go with this conception template. If they say no, then we discuss about the LARC as we normally do, which is whether the leaflet given or decline or whatever. So if the patient, for example, coming in and to be discussing about the medication issues and things like that, as obviously only metformin to be started, and then try to bring the HbA1c below 48 ideally, and then they can go for pregnancy and then stop all the other medications, especially the A's or ARBs, and then shift it to a different one if they are on them. And other than insulin and metformin, other medications need to be considered to be stopped. So the template, if they are trying to conceive, it looks this way. It's called preconception template. If they've got thyroid function, I think all the preconception, they all been picked up there. Current contraception status, using contraception, not contraception. And then it all self-explanatory. And if at all we need to refer these patients to the fertility clinic, then we can refer accordingly. There's a word preconception leaflet. At the moment, this is not very well. When we print out, it's not that clear. So as per tomorrow, we are planning to put it into a PDF version, so we can, even if we print it, we can see it's better. At the moment, it's a bit blurry. So the objectives of the preconception. Going to the next page, which is medication. So all medications, repeat prescriptions are in one place, and all the allergies will be following that place. Again, any guidance, they all put in there. So if there's any contraindication for statins or A's or ARBs, we can put it there. And then we can put as a medication review done, and medication review, we can just. But before intervening or intensification of medications, as we all normally do, is to try to make sure the lifestyle changes are made and adhered rather than adding more medication to the patient. Hence, we have put it in the red bit here, so that that can be, for just for, not that we forget, but sometimes we are in a busy running surgery, so we sometimes tend to forget. And again, in insulin passport, checked because they can bring with their booklets. If we have to amend medication, for example, say take off the allagliptin or anything else, just we can stop as we normally do. So no need to go out of the template. and then we can add acute here straight away. If at all we want to put it on the repeat, say for example, I just put it as a paracetamol or any other medication. If you put on the repeat, then automatically you can convert into a repeat template there by automatically creating the repeat on this issue, and then link up to your read code accordingly. So far, as if I have any questions, please ask. Please, I can't hear you, but I can. Can you unmute? Please? Sorry, it's a technicality. Any questions? So far, any questions, please, if you can mention. Can you hear? I can't hear Fahad. Unmute all. Thank you. Hello? Oh, listen. I can't hear you for some reason. Technically. No questions. Okay. I'm assuming there's no questions so far. So
there is a question from Alistair Snape. And the question is, one of the issues I have is making the template work in the context of a regular GP.
Regarding the management plan.
Hello, can you hear me?
Healthcare management care plan. I think I got a question from Alistair. I can't. Can you unmute here, please? Sorry, Alistair. I'm just talking to Fahad. Hello, Alistair. Can you hear me? Can't hear you. Unmute all. Unmute all. Hello, Fahad. Alistair.
Yeah, you can hear us now.
Hello.
Can you hear us?
Can you hear him?
Yeah. Here?
Can I speak to Alistair from this one? Hello, Alistair.
Alistair's microphone is not working.
Come back in there. Going back to the mute. Yeah. Going back to the next management plan. So we can put these two boxes as I can hear myself. Okay. We can pick these two boxes, which is the diabetic annual review done, and
there's a
self-management plan agreed.
Hello? There is a question from Alistair on the system.
Yeah. No, I can't hear. I can hear myself.
Sorry, Farooq, I can't hear.
Can you hear us? Can you hear me?
Hello?
Can you hear me?
Yes.
Yes. We can hear you fine.
Thank you.
Hear you fine, and there's a question from Alistair in the chat.
In the chat,
Chat box.
Okay, 1 minute. I can't see the question from Alistair.
You saw it earlier on.
I'm just checking the Alistair's question.
The question is, one of the issues I have is making the template work in the context of a regular GP appointment. It takes too long.
Correct. I agree with that. Hence, I was mentioning that we are trying not to do this as a regular GP appointments. We're doing as a GP or a practice nurse diabetic clinics where we need 15 minutes of this appointment, as most of these patients are long term. So the studies have showed that if you do a good initial timing to the patients, the follow-up appointments will be reduced. That's the reason behind. I agree exactly what Alistair is mentioning, that it takes time. But like we said earlier, 15 minutes for the HCAs to do all the blood tests, food checks, everything, and then patient comes already with their medication list in them, and they know their blood results, so we can take it next step forward. Of course, it can take sometimes more long time, but I've been using this for the last 14 months now, from the 2017 November. Initially, we got only 10-minute slots, but slowly we have arranged it that way that it's 15-minute slots for both HCAs and also 15 minutes for the practice nurses, GPs. So hopefully that should be okay, I think. But in long term, it will calm down with the because patients are more I can say more. Then they know what they're taking the medication wise, and they know what the doctor has said. So rather than getting a phone call later on after the review, or maybe so they're more informed. We can say that way. Thank you. And okay, I'm going for the next one, which is mainly the management plan. So we normally do the recall, and then all the vaccinations will be put in here. We're trying to put a new box in here where the medication reviews can be typed into. So new recalls for diabetes, as we normally do. And then after you complete this session, try to get into it's like looking at a Word document and saving it. So this is like a save button on the top. It says next consultation / contact. Unless you save whatever the data you have put in, it won't be printed on the care plan. So it goes into, and then we'll link it. And then you come back to the first page. But unfortunately, we tried to discuss with the SystmOne Bureau there where it should come back to page where we left. And it is not doing that because it is some technicality. So it goes back to first page, and we go back to the management plan as we did before. And then management plan, as we discussed earlier, it looks exactly the same as what the patient has received when they got the interim results. The interim results they can receive by email or post, whatever the surgeries do that way. But here what we are doing is to get the previous HbA1c, current HbA1c, and the comments what we made in that notes. It should be picking up. But at the moment, the HbA1c read code is being used differently. So tomorrow it should be coming up there. Same with the blood pressure. We have asked the SystmOne Bureau to do the same thing for cholesterol, previous one and the current one, and the non-HDL, previous and current. Same with the kidney function tests. And all the comments what we made in there, it should come up here, and it's extrapolated there. And this patient takes with them, and then hopefully they're more informed, and then if they got any queries first, they can refer to the care plan and then take it forward. So the the feedback which I got so far has been good from the patient's point of view. So all the exclusions, we put it in one place so that, like, vaccinations or influenza vaccine or food examinations, all put in one place, including retinopathy screening not indicated or declined, statins and ACE, ARBs, all referral letters in one place. As I said earlier, Desmond and Adam are going to be merged. So Adam is Advanced Diabetic Awareness Management. So they both look almost the same. I'm just getting this form. These things, they are going to about the read codes, and they're going to add it on as no need to type in every time when we do, because as Alistair was mentioning earlier, we don't have time. But these particular ones, they're still doing the teething because they're merged, so they have to put all together. The form looks like this, and most of the forms can be sent electronically, except weight management at the moment, we're sending it in the post. So all will be extrapolated. Even as I said earlier, the HbA1c was tweeted at, and then they couldn't get the new read code, so they're going to put that as well. And when we want the patients to, for example, if they come for something else, and then we decided to repeat the HbA1c in 3 months' time, or repeat USNDs or anything, whatever, if you need a path link or eyes, again, they put it on the right top so that we can directly go into the eyes. And then order test is that way. So this is about the live demonstration. And then measuring about the out of target patients. We got into the SystmOne. If you go into SystmOne, it looks this way, out of targets. All the top three: HbA1c, blood pressure, and total cholesterol. It's in the diabetic care planning 1819. So from the we just compared the NHS England and the CCG. So slowly we are improving, but we still need to a lot to with the catch up. Hence, and the structured education within the 12 months of diagnosis is very important to be. Hence, we are integrating. And then good news is the ICDS team are getting on to the SystmOne, so that will be useful for both of us, including the primary care and the secondary. And with the out of target measurements, we can put it on the Excel sheet. Just wanted to demonstrate this live. So I just taken the names and contact number of my patients, but this is how it looks like. So all the blood pressures, HbA1c, and total cholesterol, we can take it, and then we can arrange in a way by color. Green being within the normal range, orange where there is in between, and the red. So for example, if you can take all the greens for the blood pressure, and just, or if you want to target only the HbA1cs by orange, where we can so all these patients can be seen, and then we can adjust accordingly. So for example, you can curtail the, so if you put all in the reds, this is how it's coming up. These are all the patients we need to target, and then we can get their contact numbers, and then we can get the patient data and then contact patient or ask them to come down for the reviews. Same thing, you can just undo that. And these are all the patients who are on normal blood pressures, but the HbA1c is going up and down. Same with the total cholesterol as well. So we can target patients according to the colors. So far, what we have achieved, this is what more increased structured education places has been allocated through the CCG funding. So we got increased structured education referrals, and we have done more than 3,000 care plans, which is very good from the care plan point of view. And then increasing the food checks, mainly for got more funding through the podiatry team, and they've been very helpful. The reduction in the major amputations, and the forecast is to get further high in this calendar year. And then reduction in the minor amputations. As part of this scheme, and we are also doing the diabetes prevention program, which we have been doing very good, actually, nearly just above 4,000 referrals. And then that's the next we can discuss. So these are the references which I took it mainly from the Year on Care and diabetes.org.uk. Thank you. Any questions? I'm open now, please. I can hear all of them now. I think that's good.
Yeah, you should be able to hear us.
Yes. Can you hear me? There's a bit of a background noise.
Anybody has any questions to ask, either you can ask us directly via your headset or you can type it through on the chat box or the question box.
Or any comments?
Can you? I can't hear now. Okay. Yeah, I can.
Right. Susan has a question.
Susan Bird. Yes, I mean,
Are you worried regarding time and this designated healthcare assistant appointment? So I'll try to do all.
that's again, it's a bit, we need to negotiate the time, I think, Susan. Anything else? Okay. Thank you very much for coming to the webinar session. Thanks,
I think so. One of the Heather
Miss Parrish from Rothway. Is she there? I can see the hand out. Heather, can you hear me?
Hello, yeah.
Hi. What's the question? Sorry, I didn't. You raised the hand here.
Yeah, can you hear me?
Yes, I can hear you, Heather.
Oh, right, okay. Well, I actually wrote the question on the thing, but what my question was, when you send out the results to patients after they've had their blood things done, they obviously get sent out all the details then, and then they come in for their appointment with either the practice nurse or the GP. At the end of that appointment, do you then print out again all of their results and any advice that you've given them, or do you get the patient to fill in on the letter that you sent them with their original results, any advice given?
When the patient comes back to see us again, the second launch, so most of the patients, they can bring that paper, but we are not writing on that one, so we are reprinting the another one, because that particular one, the reprinted one, will also have all the thing, and we need to address the patient comments as well. So we document in the following the the latter one. So patients can keep them together. But if we start writing in the patients by hand, the one which they bring in, that it's not, data is not kept in our records.
No, sure. Yeah. Okay, yeah, sure. Okay, that's fine. Thank you.
Thank you.
That's great, thanks.
Thank you very much. I can't see any further question. Any hand raised? Question. Please send a text if you can't hear me. I mean, we can have chat here as well, and then I can chat back. Thank you. Thank you very much for inviting Fahad. Thank you.
You're most welcome. And if there's any questions, you can always email us. The session which we have done today will be also available on our intranet, the recorded one, and we will be visiting the practice managers forum shortly as well, because in next financial year we will be bringing some more additional parts, especially the gestational diabetes, which is being highlighted by most of the people as a concern. So we will be bringing some more additional stuff for gestational diabetes along with some payment as well. So GP surgery should be happy. So, but that will be I'll reveal those in the practice managers meeting and board meetings. But for now, if there's any questions or queries regarding this, please do let us know. There is a full half-day training available for anyone who like to join us on 7th of February. It is half-day event. For that, you please get in touch. If you have not received an email, please send us an email and we will get back to you with that. Otherwise, you can send your if you like to join in, please do get in touch with Colette, and she will get you registered into that event. But for now, thank you all for coming and joining us. That's all for today. Thank you.
Thank you very much.